think we should get started. Okay.
Recording in progress. Okay.
All right. So, hello. It's great to have you all here today. I want to welcome you on behalf of the NF Collective. We are 7 organizations that work together along with Dr. Viscaccio, and we want to welcome you all here to our community NF webinar. We love that you took time out of your day to come and hear about MEK inhibitors. My name is Tracy Wertman. I run the Littlest Tumor Foundation. We have an amazing panel today that is going to speak with you. We have Dr. Viscaccio, who we all consider an NF treasure
Yes.
of a doctor in the NF community. We also have some patient advocates that are going to tell their stories, Hannah, Kelly, Samantha, and Michelle. So with that, I am going to pull up Dr. Viscaccio's slides and let you guys hear all about NF. Okay, his slide. Here's where the first ones too. This is a technical difficulty, you guys. I have them. Okay. Here we go. I have them right here. Thank you for your patience. All righty, there we go. I hope everyone can see that. And it would be great if everybody could just in the chat, like just put where you're from. That would be great. And put any questions you have in the chat. And we will try to answer all of those at the end. All right.
Okay. Can you make that the screen? Yeah, there you go. Perfect. Okay, so this I'm Dave Viscaccio, and I'll introduce myself a little bit more as we get into the talk. But this was the title that came from our team, Understanding MEK Inhibitors from Clinical Trials to FDA Approval. But I find that the FDA approval part, that can get pretty involved. So I'll skirt the issues on that a little bit. So my title is really things to consider as you contemplate going forward and getting on, and not just MEK inhibitors, but any kind of therapy you need to be considering. So in the next slide, you'll see I have some disclosures. I do have some, I'm on the speaker board for Alexion. I'm a PI for contracted funding for a clinical trial site here with SpringWorks. But for the purpose of this webinar, I will not address specific MEK inhibitors. I won't be comparing, I won't contrast, but I'm going to focus my comments on the broad category of MEK inhibitors. And any other comments that I provide are really with respect to clinical trials in general. And my comments reflect my own views, do not represent views of other agencies or institutions. I have not received any funding for this educational webinar. And my disclaimer is that I'm a geneticist. I'm not an oncologist. And you'll see that I make reference to it a little later. That's a little unusual to be using what might be viewed as an oncologic drug by a geneticist. But I think there's more and more of us who are feeling very comfortable in using MEK inhibitors. Next slide. So I'm from the University of Utah, and I worked in Ray White's lab. And I guess one of the reasons I feel very comfortable as a geneticist using medications in this way and treating what might be viewed as a tumor, solid tumor, which it is, but it's not the malignancy in that sense, right? These are benign plexiform neurofibromas that we'll be really talking about with respect to the MEK inhibitors. But I wanted to point out the building that Ray White's group, where Ray White assembled a team to look for the NF1 gene, is pointed out right there in the middle of the University of Utah Medical Campus up against the Wasatch Mountains. Yeah, that building is still there. There's a whole bunch of other ones that have been torn down, but that one's still standing. It was up on the 6th floor. And it was about 2.5 years of toil with, I'd say over the total, probably 10 to 12 of us that were working in that time frame. These days, genes are found by doing sequencing of the genome, but back then it was a little bit more laborious. And I guess what I learned from that was I could have gone off and started trying to clone other genes for other conditions. I had the techniques in hand by then. 2.5 years, you learn a lot. But the families that I met, I really enjoyed, and I really decided to focus. And one of the goals that I had was towards the end of my career that we would be treating specifically. I never thought that we would completely cure this condition, but treating effectively manifestations that really affect quality of life is for me the key. So next slide. There we go. Here are the objectives that were outlined by the NF Collective. And I'll focus primarily on the three top ones, just to have provide some knowledge to help you make informed decisions about treatment options. And then we'll talk a little bit about the history and data behind MEK inhibitors with the focus on their application for plexiform neurofibromas. And then we'll break down the clinical trial phases, and that's what I'll start with there, the clinical trial phases. And at the very end, we'll talk about how do you keep up with the ongoing research. Next slide.
Oh, there we go.
And so this, there's so many slides out there, so many images that you can use for how do you get a therapy that starts from scratch, something that somebody has an idea that this drug might help a manifestation for this condition, for a condition. And there's a lot to it. And so this is one of the diagrams. I decided to take it because it comes from the FDA website. And this has to do with just the new drug development and review process. And you can see on the left-hand side of the screen, there's the synthesis, purification of the medication, and a key role. So there's a lot of the chemists make a lot of concoctions, right? And that does take time. They've got to be deciding what pathway are they treating. So there's a lot that goes into that. But I would say the key component for pharmaceutical firms and anyone who's trying to develop a therapeutic agent is really the preclinical testing through animal trials. And whatever we say about how cute the mice are, they really play a huge role. And I can say that it took about 10 years before we actually had a mouse model for NF1. And that was driven by a lot of folks, and it congealed with the Preclinical Trials Consortium that was supported through, at that time, it was NNFF, and the development of these animal models that really, I think, replicated the NF1 phenotype as best it could. And once we had that model, then you can start testing the different medications. And so there's our treatment drugs, and there's short-term, long-term. And then you do have to think about which institutions are going to be doing not just for human trials. I mean, there are requirements of how we treat investigative animals, and so that's really a process that I think, can really only be done in academic centers. And what you see is on the bottom, you can see that there's an industry time, and that's just in the white, and the bluish coloration is FDA time. And so once you think you're ready to go and you've got some preclinical information, that's when you touch base with the FDA. And it can either be the investigative team, or it can be, maybe you now are trying to recruit the pharmaceutical firm to take this forward into a clinical trial. But somebody really needs to talk to the FDA and share what you're proposing to do. You don't just throw out a clinical trial and get all your results and then go to the FDA. You really talk with them beforehand, and they give feedback to say, these are the things you should be looking for. And the key thing that they'll try to identify with you is, what is your primary endpoint? And you'll see as we go through this, the primary endpoint for the MEK inhibitors was the volumetric change in the plexiform neurofibromas. So there is an IND, so that's an application that needs to be applied to use this new medication, and that's not an easy thing to get, and you have to decide who is going to be the holder of that IND, and usually it turns out to be the if it's an available drug and you're repurposing it, it could be the principal investigator who's pushing this forward with the sponsor. But once you have that, you can go forward, and there's up on the top, you see there's phase 1, phase 2, phase 3. Phase 1 trials are really dose-finding trials. And historically, we would push the dose to see if to find safety concerns primarily. And that doesn't focus necessarily on efficacy. You can gather that information, but it's really all about safety. What is the highest dose you can give safely? Then you move into the phase 2, which is a combined safety plus efficacy. And that's what we typically think about. And that's usually well-selected, almost too well-selected individuals to participate in the trial. And so they can be cherry-picked out of the general population. Well, not the general population, but what we would say is if you took 1,000 people that had plexiform neurofibromas, you could really pick out who might be the ones that you think might respond. And that's one of the drawbacks for phase 2 trials, and why sometimes the phase 2 doesn't transition into a phase 3, which is much broader, where you're accepting many, many more individuals who have maybe other clinical manifestations. They might not process drugs the same way. So there's a lot of reasons why phase 2 results don't bear out in phase 3 trials. And once you show that the medication is safe, that's the key thing, and effective for whatever your endpoint was that you selected, now you go to the FDA for review, and they have a certain amount of time to review it, and then they can share that this is one that can go to market, if you will. And with that, there's a label that comes with it, and that's one of the key things that any of the sponsors will work on. So that was a long-winded discussion about the process. There's on the next slide, you can see it's a little easier to see the time frame. So up on top, you've got target discovery, you've got the lead identification, looking for optimization, animal testing, and then you move in time-wise, phase 1, then phase 2, which is more of the clinical stage, and eventually the market launch. And then phase 4, I think now most people say, okay, once you have it out there, don't quit looking for how things, not just for the side effects, but how effective is that medication? Because once you get out in the real world, all kinds of things happen. People miss doses, they just decide not to be on for a week, and there's many things that can happen more in that real world phase, and that's something that we're paying more attention to. So I pulled this figure from an article out of JAMA, which is the Journal of American Medical Association, fairly recent, 2024. And in this, they're looking at the cost, and I'll show you that later on in the talk. But we always look at this and say, oh my goodness, who can pay for this? And we realize now NIH really cannot cover these kind of trials. It really is pharmaceutical firms that are about the only ones that can carry out the phase 3, phase 2, phase 3 trials. Next slide. So let's go back to, it's important to know what we're treating. We need to find the target, and the beauty of finding the NF1 gene was sorting out what did it encode? What did the protein do? And this was a pretty exciting time. It took about, well, less than a year to figure out that the DNA sequence coded for a protein that interacted with RAS. And what you see here is the the black line, the thick black line represents the cell membrane, and this is in any cell. There are growth factors that talk to receptors that are part of that membrane, and they initiate a series of steps that loads RAS. RAS is one of the first oncogenes that was ever identified. It is really an important molecule for many, many cells, and has been historically one of the genes that is most likely to be mutated and to be activated in cancers. And so you can imagine once we showed that neurofibromin downregulated activated RAS, there's a lot of oncologists that got involved in this. And one of the reasons is that RAS had been around for about 15 years at that point, and nobody could figure out how to target it. And it's just been recently that RAS itself, the protein RAS, has been targeted. So I think the oncologists were saying, well, gosh, maybe if we targeted neurofibromin, we'd be targeting a lot of RAS associated cancers. So there was a lot of activity for a number of years. And one of the people, I think on the next slide, maybe I bring out who was really driving that, a good portion of it. So next slide, Tracy. There we go. So Dr. Wiedemann, those of you who know Brigitte, she was relentless in trying to sort out how can we target this pathway. And what you see in the figure is that there's a lot of places that you can start the targeting process without, and this is with the RAS pathway. And you can see that the FTIs, so those are farnesyl transferase inhibitors, and those could potentially keep RAS from actually getting to the membrane, which is where it has to be in order for it to exert its effects. And so those are statins that could affect that. You can see as we go around the left-hand side, there's other inhibitors that can hit BRAF, which is part of the downstream pathway coming from RAS. And then you see the MEK inhibitors. So there's these are coming off the shelf. They've been around for a while. And Dr. Wiedemann just went through it and tried to, year after year, get a new targeted therapy, and finally landed on the MEK inhibitor. And part of that was the Mouse Consortium and Nancy Ratner's work, where she took one of the MEK inhibitors and demonstrated in her mouse model that she could reduce the size of plexiform neurofibromas. Next slide. So this is just another depiction of, so what does it mean to have this signal? Well, the bottom line is when RAS goes through RAF and then MEK and then ERK, ERK comes into the nucleus of the cell and starts turning on different genes. And these genes change the pattern of growth for those cells. And so if the signal, there was too much signal coming through MEK, and so if you could diminish that signal, you could decrease all the genetic, all the genes that were turned on or turned off, depending on the signal, by that pathway. And in theory, that should reduce I guess the drive for those cells to replicate or to proliferate. Next slide. So this was the first study. You can see this was in New England Journal of Medicine, and Eva Dombey was the first author on this paper. But you can see Dr. Wiedemann down at the very bottom of the author list. And what they're showing up on top, just to get you oriented, they're showing the volume of the tumor, right? And so this is percent change in tumor volume. Once you start treatment, they had 3 different doses, and this was in 24 children. They elected to go with children because we knew that was the most active time for plexiform tumors to be growing. And these are the different tumor sizes. You can see 2 tablespoons versus one that was quite large, 2 1/3 gallons of volume. This was an oral study drug used for 6 to 56 months. And what they showed is that the dose could actually be lowered and still be effective. And so the side effects they found were skin rashes and GI disturbances, but the tumor volume, and they made a cutoff at 20%, saying this was a success if the tumor volume decreased by more than 20%. Those individuals who didn't drop or didn't decrease in size by more than 20%, I wouldn't say that anybody thought that that was ineffective, because as some people know, these tumors will grow in childhood. And if you can keep it from growing while the child continues to grow, to me, that's a victory, but that's not how they viewed it as oncologists. That's my geneticist talking. Next slide. The next study was a continuation of that 4 years later, and that was following these individuals much longer on one dose. So this is 50 children, all less than 18 years of age, and older than 2, certainly, on oral study drug twice a day at 25 milligrams per meter squared. Again, the tumor volume was by MRI, and they also collected information on pain, quality of life, disfigurement, and function. And safety monitoring was typical. They found 117 different adverse events. That's what we call AEs, or adverse events. In any clinical trial, you keep a log of adverse events, whether you think it's related to the drug or some other finding, which is not an easy thing to do sometimes when you have manifestations for NF1 that are so varied. It could just be related to the condition itself and have nothing to do with the treatment that someone's taking. But in this manuscript, you see figure 1, they're comparing it against the natural history of plexiform neurofibromas within NF. And you see on the left, it's progression-free survival. So that's just the way the oncologist can depict this. And in the natural history study, you can see that these tumors would progress over 3 years. So that doesn't mean they weren't surviving, right? These are individuals who are surviving. These are not deadly tumors, but they were continuing to progress. And what you see in the study drug group on the red line up above is that those individuals were not progressing over the 3-year time frame. So that was lovely to see. Next slide. The third study was through the NF Consortium, funded by the Department of Defense, a different MEK inhibitor, and they found a similar finding. And if you look down below, there's an example of the plexiform tumor as they were showing how they measured volume. But these were 19 patients between 16 and 39 years of age, and some had a partial response. One had progressive disease, and you can see that over to the left, that bar that goes up. So that volume continued to go up from baseline, which is 0. And what you can look over is there was only one other individual where the tumor actually got larger. Then another one stayed the same. And then all the other individuals, you can see that there was a decrease in volume. And once you hit that magic 20% volume loss mark, you can see it switches over from blue to pink, saying this is really a success. And then they also found with this different MEK inhibitor the same kind of rashes. There was also fatigue and nausea that fits in the GI. Next slide. And this is the most recent one that you're probably aware of. And that is, again, with the same study drug that they used in the prior study. And this is looking both at adults and children. So the big difference is looking at adults with this inhibitor, MEK inhibitor. And the dosing here is 3 weeks on and 1 week off. 41% of adults, 52%. So I just say around 50% of individuals responded with more than 20% reduction. You can see that on the panel on the right. Same kind of waterfall kind of plot that you can see. A few individuals had progression, but by and large, most individuals showed a decrease in tumor from their baseline. The treatment-related adverse events, almost everybody had some kind of adverse event. But we grade those events, grade 1, 2, 3, and even 4. And of the grade 3s, 16% of adults had a grade 3 and 25% had of the children had grade 3. And usually when we think of grade 3, that usually requires some kind of intervention. And it could be as simple as treating with any acne treating drug that's available. Next slide. Oh, going back to the cost, I'm only going to spend a short time on this one. So this came from that JAMA article, and what you can see is in that in the reddish beige color, that's the amount of research and development spending that was put forth by the pharmaceuticals from 2008 up to 2019. But I wanted you to look at the light blue, which is total sales. So total sales versus R&D, we shouldn't be feeling sorry for these pharmaceutical companies when they start belly aching about how much it costs to bring a drug to FDA approval. So next slide. So here we have an FDA approved drug. Great. One of the concerns, there's a warning label on this, contains an FDA approved drug, right? So, so this, as funny as that might be, it did transform. I think it has transformed our NF clinics. We now have a reason to be doing MRI scans to find tumors that are growing, and we now can treat without having to do surgical resection, which all of us know that can be quite morbid and not really solve the issue. Next slide. And I'll just zip through these. So this is an example of somebody who came to our clinic, and you may not appreciate there's a fullness up in the upper left neck, and on MRI scan, you can see that there's a significant tumor that's there, and the surgeon has to decide, should they go in and try to resect it and potentially nick a nerve, or should we try MEK inhibitor? And I think the panel on the bottom right is 4 years prior. So you can see a difference when you line up the two bottom panels. You can see that there's a nodule that is really sort of taken off. And that had created some pain because just the tumor as it's growing, it stretches what encases that tumor. So it would be the nerve sheath. Next slide. So I think about the management issues with MEK inhibitor therapy, just to give you a sense of what kind of numbers. And at least in my clinic, I think about 1 in 5 individuals with NF1 have a plexiform neurofibroma that emerges in childhood. A lot of times it's just small, doesn't really cause a problem. It may be a surface one that we know never transforms into a malignancy. But if you do the math, if 1 in 3,000 individuals have NF1 and 1 out of 5 have a tumor that could potentially be treated, we're talking about 1 in 15,000 people across the world that potentially could benefit. In Utah, I think of our oncology service catchment, it's about 5 million. And so if as many as 300 individuals in the mountain states could potentially benefit from the medical therapy, to put that in perspective on the next slide, I think I try to capture how things are going this fall. So if you pack our Rice Eccles Stadium, football stadium with 52,000 fans on some non-COVID Saturday where it could be filled up entirely, three individuals in that group might benefit from MEK inhibitor. So this is I think a game changer for our NF clinic. Next slide. So we need to think about this as a non-cancerous tumor, generally emerging in childhood. It can progress, it can have symptoms, especially pain. And so the considerations we have to review are, is it symptomatic? Is it resectable? Who wants to take medication daily with close monitoring? That's a real commitment for families. There are children who don't really take pills. And so there's now formulations where we can take granulated samples, and it's not quite such an issue, but it was at the beginning. And then if you look at the benefits, 2/3 of individuals respond, and they have to compare that with the side effects. So you're trying to weigh this as a family, and who are you going to call? Next slide. Nope. Sorry, not Ghostbusters, but the next slide. That might do it for us. So, so the NF providers, I think, are in the best place to call this. I think that the oncology teams, some of them do follow individuals with NF who may not ever develop a plexiform tumor, but usually the oncologists are seeing the tumors that are progressive, that are symptomatic. And so their sense of what NF is driven by the tumor, whereas in the NF clinic, an NF provider knows the whole scope of what someone may be experiencing. And that tumor might just be a little piece of all the other manifestations they're dealing with respect to NF1. So there is we recognize that the MEK inhibitors were here to stay in the NF clinics. And so there's a patient information sheet that's been developed, but I wanted to show on the next slide well, these things are to consider, and it's really safety. You really have to think about safety with this. Although we were talking about using MEK inhibitors in a different condition called Costello syndrome. And I remember a father standing up at the end of all these presentations saying, this is all fine and good if you can help my child's heart, but if you change my child's personality, I'm going to be really ticked off. And so that's kind of a reckoning call. But you need to think about effectiveness, side effects. What are you hoping to treat, and what are your options? So next slide. So this is the manuscript that was developed through the CTF-CCAB, the Clinical Care Advisory Board. And with this, I think with these guidelines, I can say now even a geneticist can take on this role. So next slide. I just wanted to go through highlight some of the things that this manuscript shows. It really summarizes the most common side effects for all MEK inhibitors, at least 3 of the MEK inhibitors. And you can see cardiac is up there, but in my experience, there's not really an issue with cardiac or with ophthalmologic issues. Those are the two most worrisome side effects. But you see diarrhea, fatigue, nausea, vomiting, and then rashes. But the other one that sneaks in, and I have no idea, and I've talked to a lot of people, where in the world does paronychia come from? And I'll show you on the next slide what I mean by that. It's really tough to deal with. You can see it looks like an ingrown toenail, but that's not just what it is. A lot of our podiatrists take those nails off trying to solve this, but there's still inflammation that occurs. And why it's the toes and not well, sometimes the fingers are affected. But then looking off to the left, you can see this is a pretty significant rash. And if you're a teenager and you're dealing with acne and you get a rash like this, you're going to really be thinking, do I want to continue to take this for long time? Next slide. I'm almost done. So these are just some proposed surveillance of MEK inhibitors. So this is what if you're in a clinic that's not affiliated with an academic center, I still think that this is something that can be taken on by providers. Next slide. And so I think we've gone through most of these objectives. The last couple of slides are insights into new and ongoing research. So let's see what the next slide shows us. Yes, clinicaltrials.gov. If you haven't heard of it, it's a pretty easy thing to use, although if the government is not in session, nobody is keeping this up, and so you have to use this with a grain of salt. But in this, so it's easy to get to, clinicaltrials.gov on any computer. You just put in the condition, and in this case, we're going to put in NF1, and on the next slide, you'll see what comes up. So it's the first one that comes up is one that's not recruiting. And so every clinical trial gets a number, and here it's not yet recruiting, but you can see the title. It sounds intriguing. but I wanted you to bring you up to the very top where it says search details, viewing 1 out of 10 on that page, but there's 289 studies for NF1. You would never have thought there's that many studies. As you go through it, you'll realize that they keep in studies that have been completed and some that are not recruiting, like this one, and some that just quit early, I should say. But then if you look at the very bottom, you can see locations. So this one happens to be in Boston, Massachusetts. There are, it's really nice to know where clinical trials are being done because nobody wants to travel halfway across the country to participate in a trial. So this is a way you can keep up on things. And of course, word of mouth is always okay, and newsletters are okay as well, but this is the official place to look if you're waiting to see, is there going to be a drug that comes out of one of these clinical trials that's ready to go forward to FDA approval. And final couple of slides, I just want to share where I'm from. So this is Utah, the southern part of it. Bears Ears is a national park at this point. And just to show you where it is on the next slide, and to say thank you. So here's Bears Ears. There's a long, lonely highway up on the White Mesa, but Utah is on the left-hand side, so you know where that is now. But within Utah, it's down in the south and east corner of Utah. So with that, I'll close and let's move on to the panel.
Okay, thank you. Stop that share. There we go. Okay, I will get the next slides. There we go. Okay, here we have Hannah. Him will be our next speaker. All right, Hannah, just let me know when you want me to go forward.
Cool. So I'm just here to talk about, I guess, my journey with NF1, someone living with a peripheral nerve tumor and starting the MEK inhibitor, my decision to start it, and I guess my life now. So we can advance to the next slide.
Wait, did I put it on play? Wait. Maybe I have to scroll
I
down.
think you can just scroll down, yeah. So these are some people I met through the NF Young Adult Program. So this is where I met Tracy. Yeah, just how I got started with the NF Collective, I guess. So next slide. So my journey to start the MEK inhibitor was due to my plexiform in my neck area. Um, I think I come in a kind of unique situation in that I made a lot of medical decisions on my own because my parents didn't have a high like health literacy. And so like starting from a young age, I went to my doctor's appointments alone. I had to learn about NF1 by myself. But the plexiform in my neck really started bothering me around college. I think it did bother me when I was younger, but like I just thought of it as like a normal part of growing up. So like if you see that little graphic, like, are you feeling any pain? And I say like, oh, it's the normal amount of pain. And typically most people don't feel pain. But I think for a lot of people with NF, we feel pain around our plexiforms. But started to notice like in college, I couldn't go to sleep at night or it kept waking me up. So as a college student who was already getting no sleep, I was getting even less sleep. Um, so I like reached out to like some area doctors who I knew were running clinical trials through like CTF because my second year of college I did research, not research, I interned with Children's Tumor Foundation and I like read about all like the MEK inhibitor clinical trials going on. So after graduating, I think that was in 2019 during COVID. I like transferred my care to Nemours in Delaware, where I was able to start on the clinical trial. So that's when I started the trial due to pain, and those are some of my plexiforms. And as other people go through too, I went through like all the side effects, like the rash, the nausea, the vomiting, but I kept staying on it. And then my tumor like stabilized, like my pain also stabilized more. I also went through other medical stuff where I had to like stop and start the drug. So I had experience with like, oh, what happens when you like stop the drug for 3 months? Restarting the drug was also tough. But if you go to the next slide, I was able to like sort of like I guess restart, not restart my life, but continue on with the things I really love doing. So I finished undergrad. I went to my master's program. So this was my undergrad in the Philly area. And I really wanted to become a doctor. I felt like this medication kind of put me on hold for a few years because the clinical trials, I had to be near the site. And applying to med school, I like limited my scope to a small area, geographic area. But once I was moved out of the clinical trial, I was able to like broaden my medical school search zone. So now I'm in med school. So if you go to the next slide, this is just some of the odd jobs I picked up as I um, was, I guess, exploring med school options. I worked as an ophthalmology tech, a dialysis tech, and then today I'm in my second year of med school. I'm still on the MEK inhibitor. And yeah, it's really funny because today I took an exam on neurology and there's a question on NF1, but the symptoms were of NF2. So I had to go to my professor's office and talk to him about NF. But yes, I am AM2 now.
Wonderful. Please, everyone, please start thinking of questions for Hannah. And now we're going to have the mother-daughter duo, Michelle and Samantha. And I
That's
have your,
No way.
wait, where are my pictures?
I don't think we have fancy slides.
We just have funny pictures that
No,
also aren't in order.
I did make you some slides.
Oh, you did? Okay.
Our
yeah.
pictures are not in order.
Thank you.
I did not organize them.
Yeah, I did. Okay, so here we go.
Oh, hey, that's us.
That's you guys. Yes. All right. Play and continue to share. I'll let you guys go ahead. It's your turn to share your story.
So this is us at my doctor's appointment last month at UCLA. I started out going to primary children's with Dr. Viscotral, and he was the one that informed us about the clinical trial happening at UCLA. And I've been there for over 5 years now on the medication. The beginning was definitely really, really rough with the side effects. But once I was diagnosed 10 years ago, and when we started hearing about clinical trials, Mom and I both knew we wanted to get me on one, no matter where it was or what it took, because my pain was so awful. In just the area where my plexiform is, we wanted to try anything we could before rushing into surgery. So we found out about this trial in 2019, and I started it in 2020. Yeah, I don't know what other pictures I sent. Oh, this was me after my surgery in December of 2025. Or 2015. I'm
There you
sorry,
go.
December of 2015. I had a non-ossifying fibroma in my left femur.
Ooh, you should get the picture and show.
I have a picture on my mom made me a lamp
So
that
that's
has
That's the x-ray of her leg. That's the tumor.
So the tumor's right there and it grew more.
So yeah, I made her a cool little nightlight. All right, go ahead.
So I had that tumor removed. My femur was also fractured, and I think part of my kneecap was. That's how we found out that I
That's a
had.
kneecap
I don't know, that's what the doctor said.
Okay.
That's how we found out that that I had NF. We had never heard the word neurofibromatosis before 2015. And we also found out that mom was the mutation. So mom gave it to me and mom went her whole life, not knowing she had it. And luckily my little brothers don't have it, but we found out only a little over 10 years ago what NF was, and it definitely turned our world upside down.
Huh.
I don't, this next picture. This is, so you can't.
Can you see the
you
bottom
can't
of
see
it?
the bottom of it. I have a teddy bear
She has her teddy bear strapped in on
that
the
I
plane.
bring with me everywhere. And it's strapped in on the plane. Also at our
Because
last
of
doctor's
course it is.
appointment. Hey,
Safe-
Bear has to be
Yeah,
safe.
Safety first.
We just try to make the best out of the situation.
Yeah, we try to make these trips fun. There was a lot of anger from me in the beginning of this diagnosis. So yeah, we do try to have a lot of fun.
Yeah.
That's how I deal with my
That's how we
anger
cope.
issues.
Yeah, we just try to make the best of it and try not to let it affect us.
Yeah, that's the
This is
nightlight.
the nightlight that we showed you guys. That was my tumor. This is, we have like designated picture spots that we call them, our photo ops,
Yeah, this
that
is-
we take a picture at every single
Every
time
time.
we're there. So this is one of them. We just, I don't know. It's what we do every time. We see how much we've changed over the past few years, 5 years. This is, so the CTRC, that's where we call it my trial appointment. That's where I meet with my doctors and my team. I get my lab work done. I have to do vitals, EKGs, all of the things. But this, we call it our fun appointment. Our other appointments, something always goes wrong. So this is like our relaxing time
and you
before.
know, every 4 months, but it used to be like every month, I think.
Yeah, the first 2 years, 2.5 years, 2 years, I was there every single month, and then they moved it to every other month. And for the past, I want to say year and a half, maybe, it's been every 4 months. And with the trial that I'm on being approved, they asked me to stay on for long-term research because my results were so well, or so good. I had some of the best results of the trial, so they wanted to keep me on for the long-term research that they need, which is kind of crazy how the beginning of the trial was so negative with how awful the side effects were. There were many, many times that I wanted to quit, but the more we heard how much the medicine was working, my mom and I, again, making light out of the situation, would say, oh, well, my side effects were so bad because the medication was working so well. And that's kind of how we gaslit ourselves into staying on. Trying to make the most out of the situation. I wasn't able to really eat. I had really bad nausea, vomiting. I had awful acne. The acne started like 12 days after my first dose. That was the first thing that came, and I started it at 18, and all throughout puberty and being on dance teams, I never had acne. So now being a college freshman and having acne all of a sudden, but having like awful acne that you have in your younger years of puberty was not easy. And mine also went like on my body. So it was around my plexiform as well. Um, yeah. I don't know what else was bad. The hair thinning was bad. The fatigue was bad.
But the results were good.
The results were great. Yeah. I don't know what else. Oh, I was making myself at home. This is where I get my MRIs.
There's a lot of waiting when we go to these appointments.
Yes. So we fly, all my appointments are on Mondays. So we fly in Sunday night And then we have all 4 appointments Monday, and then we fly home Monday so we can make it to work on Tuesday. So we just miss as little work as possible, and I miss as little school as possible. Um, so this day, everything was going well until this appointment. Everything was running really, really early, so we go to my appointments just in case someone doesn't show up, and they can take me earlier. It turns out that the MRI machine broke, so we had to go to the Santa Monica location to get my MRI. But it's a lot of sitting and waiting, and again, we try to make the most out of it. So I took a little nap right here,
Yeah.
as I do. Oh, this was me and my parents at this year's NF Hope concert. We've gone every year for the past 9 years.
Sounds
I
right.
think. In 2019, I was the Paul Bodnar Memorial winner, which is just making lemonade out of the sourest lemons. And Jeff and Melanie Lebo thought that after the concert the year before that they wanted me to be that winner. But we go every year. It's a time for
Since what she just said didn't make any sense to anyone who doesn't
Okay.
know, Jeff and Melody are the ones that put the NF Hope concert / fundraiser on. Just in case you're wondering who those names were that she just threw out there.
But we try to go every year. I think we've been every year. We were also there for the COVID years virtually.
Yeah, it's
But
a good
It's a
fundraiser.
good fundraiser. This year was a little different with all of the funding being different, how they handled what is it, the donations at the
Mhm.
end. But it's
They
really,
they did very well.
they did very well. It's moving seeing how much people want there to be a difference and how much people are willing to donate
donate.
to help find a cure and to have more trials like this go through and be FDA approved. That's it.
Okay. All right. So now we have our last speaker, Kelly,
You
who
took
is
all-
an NF mom. And I want to get her picture up here.
you this.
She has a couple pictures. I have them. Here we go. You want this one though first? Yep. Sorry, I'm not a technician.
I'm just thinking it's better you than me. So I'm Kelly Carpenter. My now 18-year-old son Travis was diagnosed with NF1 at 6 months of age. He had bone structure issues show up at about 1.5 years. And at his 2.5-year appointment with the geneticist he was seeing at the time, they suspected a plexiform neurofibroma. And he got an MRI about 2 weeks later, and it showed an extensive plexiform that is in his lower back, left hip, left thigh, pretty invasive. And he was 2 years old, and like that's just like a huge shock. He was late crawling. He was definitely late walking, didn't start walking till he was after 2. And I remember the summer he turned 3, I was attending a conference about neurofibromatosis in Denver. And this story might be familiar to you, Dr. V. And I remember watching a presentation by Dr. Viscaccio about clinical trials. And I'm sitting here thinking of my 3-year-old kid just had a second MRI going, I don't think I could ever sign my kid up for a clinical trial. But as you look at it, and then as we got the information, 3 months later, I was actually signing Travis up for his very first clinical trial. Because his tumor had grown 33% in 6 months. And at that time, there wasn't anything effective. There was nothing. And like, okay, I'm from a research background. My husband's from a research background in the field of meteorology. So we were like, okay, we made our pros and cons list of what's, do we do this? Do we not? And I think the pros and cons were even at 7 apiece. And I joked like I could have flipped a coin and it would land on the side like, oh man. But we went forward with it. And, that clinical trial was not a MEK inhibitor. And he was on that for about 15 months, and he still had tumor progression. He did another clinical trial when he was, 6. That one was not a MEK inhibitor. It was a weekly injection that we would give him at home that made him feel like he had the the flu for 2 to 3 days out of the week if we weren't on top of his ibuprofen and Tylenol regimen. And then in 2015, he enrolled in his third clinical trial, a MEK inhibitor clinical trial on the East Coast. And we live in Salt Lake City, so we would travel to the East Coast quite a bit. But you can see this picture of him. So his tumor volume that they measured at the start of the clinical trial was almost the size of a 2-liter bottle. You can see we measured it out to the milliliter. That's, my nerdy meteorologist side of me and the scientific-y part of me. And then one of his best response, like it shrunk his tumor almost 40%. And so you can see that 2-liter bottle. I wish we would have gotten a picture at the start because this is 2.5 years in. And he was a littler kid, so nearly 2 liters is a lot of tumor load in him. And so you can see that it definitely decreased it. On the MEK inhibitor, he did have fatigue a lot in the beginning, the first few weeks or couple months, but we worked through that. He's doing great. He's still on the MEK inhibitor. I always tell people not all side effects are bad. His biggest side effect that's visible besides with the medication is that it turned his hair bright blonde. So it could be non-dyeable purple for all I care. And that would be fine by us. He is doing really well on it. None of the GI issues. He's monitored every 6 months and continues to thrive. Unfortunately for him and his story, his plexiform neurofibroma before he was on the MEK inhibitor grew into his femur bone, weakened his femur, and it broke for the third time 5 years ago yesterday with 10 pounds of pressure. Long story short, it never really healed, and so he decided I wanted to be rid of it. He amputated his leg in April 29th of 2021 and donated it to NF Research. Thank you, Dr. Viscaccio, for your help in that and making it get to different institutions across the country and raised money for NF Research. He is a freshman now at the University of Utah, go Utes, and studying parks, recreation, and tourism with an emphasis in sports management and community engagement. But he is doing well, and that MEK inhibitor has changed his life. It's taken away the pain, it's taken away the itching, and it's giving him a new lease on life.
Thank you, Kelly.
Mm-hmm.
Okay, so we have time for a few questions. And, let's see. People are saying, so good to see you. John from NH, my 4-year-old has NF. Don't have. They're saying how much they love Dr. Moscaccio. Can you comment on the efficacy of MEK inhibitors on diffuse neurofibromas versus plexiform? I guess that would be you, Dr. Moscaccio.
Yeah, I might take that one. It's difficult to know how to classify these types of tumors. And I would say that Travis probably had as diffuse of a tumor as you can imagine. And every once in a while, there'd be nodules that would pop up that could be taken care of. But wouldn't you say, Kelly, that his would be described as diffuse and it responded?
Yes. Yes.
I think the controversy now, or not controversy, but the concern now is that there are these discrete nodular lesions that may represent the first step away from benign plexiform into what we call an ANUP. Some people call them ANUPs. And we don't know what to do with them, but we know there are some genetic changes that affect not just the NF1 pathway, but also the additional pathway that has to do with cell division. And so once those nodules form, we don't think that the MEK inhibitor is going to be as effective. And so we're still struggling with how to follow individuals as they develop those discrete nodules within the background of a diffuse plexiform. But the diffuse plexiform responds.
Can these be used for gliomas?
Yes, MEK inhibitors are being used for gliomas. Yeah.
Okay, so here we go. Pain. Their daughter has high tolerance for pain. She broke her leg, and when she got a bone marrow transplant, but she has no pain. Is there anything she's 4 years old now. Is there anything we should do to help her find out if she is in pain? Because she never says that she is in pain, but she does ask for morphine at times. So they're asking, is there anything they should do to help out, to find out if she is in pain?
What did you do? I don't even remember.
I mean, I'm the worst person to ask. I just didn't believe her. Like her normal was being in pain, but she would tell me I hurt my knee. Okay. Talk to me when you're 50. I hurt my knee. I mean, I ignored her until, but I didn't know. I mean, I didn't know she had an F. I didn't know that pain was associated with it. I had no idea what any of this was. And once I learned, and I was like, oh, so your normal was just constant pain. Year 0 is everyone else's, I don't know, 8.
8 or 9. Yeah.
And until she's old enough to articulate, I have no advice. I don't know, because their normal is being in pain.
A lot of what we would do with Travis, especially like because that's his normal, that's his baseline. We would watch his activity. Did he if he wasn't playing cars, something was wrong. If you know Travis,
Yeah.
and so we watch that, we watch his demeanor, and even now he's a super tough 18-year-old, and are you in pain? Oh, just a little. I'm like, okay, dude, we know you're tough, but is this different than your normal? And I think like Hannah had alluded to.
I think with yours, it was if I wasn't dancing, something was wrong.
You're right. That
was for
that's
me.
that's her cars. Yeah. She wasn't dancing. I'm like, all right, what's happening?
Yeah.
Yeah.
Do the side effects go away eventually? Do they help with travel for clinical trials?
For ours, they did help with travel. I'm not sure.
Not in the beginning.
Not in the beginning. I'm not sure.
Again, I have a lot of anger. But I used to say, well, the only thing that's free about a free clinical trial are the drugs. Everything else is expensive. They do now. They do reimburse us now, but they did not in the
They
beginning.
didn't in the beginning.
What was the other question?
The
Oh, did the
side
side effects
effects.
eventually go away? They lessen.
They lessen.
They don't go.
I finally am able to eat, whether it's my on weeks
Oh,
or
yeah,
my
she
off
eats.
weeks. My off or my on weeks, mom basically put me on the brat diet. It was basically a 2-year-long morning sickness. But
Yeah.
once my body kind of got
But-
used to the meds, I was able to eat normally again.
But it was working, so
Yeah.
you weigh the good and the bad. I
Bad.
mean, so you feel nauseous several times a month. But tumors are shrinking.
Yeah, it's better than throwing up 3 times a day.
Yeah.
The only side effects I still consistently have is the hair loss and hair thinning and rashes, the acne rashes. It's not as bad, but it still flares up.
I don't see it right
It's
now.
not bad right now.
Mhm.
But the hair thinning has been the only thing that's been consistently the
Pretty, yeah.
same for me.
Okay. Are these MEK inhibitors lifelong?
Dr. V?
Mhm.
That's my understanding.
It's my understanding.
Oh, you're
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 muted.
muted.
come back.
Yeah, we just don't know.
Yeah.
Yeah.
Don't know when to, and I think enough people are dropping off because of the side effects. We need to continue to follow those individuals, and
Mhm.
even ones who were not part of a clinical trial but started later when it was FDA approved.
Mhm.
There needs to be a mechanism by which the pharmaceuticals keep a registry open so that we can follow that. And so there is a need for another trial, I would say, but it
Mhm.
doesn't have to be like the first trial that you've gone through, right? Where we're really watching things closely. Now it can be, we just have to open up our minds of how we can continue to follow people without putting them through traveling and all the additional stuff that you just don't want to do after a while.
The one thing they've told us is it's lifelong until the time comes of wanting to start a family. I can't be trying to get pregnant or be pregnant taking the meds. But then there's
Yeah, so for right now, she's on it.
Shut up. But there's also no research on what happens when you stop taking the meds and
Oh, we'll see.
the hormones and that kind of stuff.
Actually, that was one of the questions. Any documented growth after stopping MEK?
There have been in some patients where there's been a rebound.
Hmm.
So
Yeah.
of course, those individuals then would say, okay, I'm ready to go back on. But if you don't get the rebound, then, we're still talking about a limited number of people that have been on it for any, significant length of time. So we've got a ways to go. And I just hope we can continue to collect information as we go.
Mhm.
And when Travis was off, he was off for about 9 months with his broken femur, and he had a couple surgeries right before. And we did see growth in his plexiform, definitely quite a bit, quite a lot in that 9 months. So that was kind of like our trial within a trial, unknowingly, but yeah.
Dr. Viscacho, is there any progress on the cream developed to be applied to dermal tumors?
Which kind of tumors?
Dermal.
Oh, the cutaneous tumors? Well, you
Yeah.
you would think that this would work. And you saw it at least in that we don't have to be restricted to MEK inhibitors. There was a trial where MEK inhibitor was put in an ointment and then used and there were some positive results from that, but it has not gone forward through the FDA. I'm not sure where that stands now. So we had one of those clinical trials or that clinical trial was held in Utah as well. And when you're trying to choose which cutaneous neurofibroma to put the ointment on, if this, we know that these tumors tend to pop up and then they quit growing, right? The cutaneous neurofibromas, they tend to quit after they've reached a certain size. So to me, the appropriate way to go is when you notice something popping up, and people have told me that there's a little itch in the area, a localized itch, and the next thing you know, here's a little bump that's popping up.
Yep.
That is the active growth time. And so to me, that's going to be the time to try any of those ointments with MEK inhibitor in it. But I haven't seen that.
Exciting. Okay, for Samantha and Hannah, what was most effective at treating the acne side effects? My 14-year-old daughter is struggling terrible with this side effect.
For me, literally nothing. Nothing worked.
Watch YouTube tutorials on how to put on makeup.
Yeah.
It was heartbreaking.
We did every topical cream, every lotion. Mom bought me like the fancy like Accutane, acne.org.
I think it was
No, it was acne.org.
Acne.org. Fancy.
She bought me a whole between the trial and her. I tried everything and nothing worked. It was
Yeah,
really just
everything we found, everything that was suggested, everything that was prescribed, everything I found online. Didn't work.
They gave me doxycycline. That just made me throw up.
What?
The doxycycline.
That's what it was called.
Mhm.
Anyway,
They gave me that to help with it. That just made me even more sick. So I just
she learned very creative ways to do her makeup.
makeup on.
Hannah, do you have better news?
When I first started, I had really bad acneiform rash too, but it went away. And then when I restarted this time, I didn't get the acneiform rash, but I got more GI effects.
Okay.
But when I first started it, I just did everything the dermatologist told me to do. We tried like a bunch of different creams. I think I finally landed on tretinoin and then like very mild like face washes. But I think what's different this time is they like started me on doxycycline before I actually went on the drug. So I think it's like a trial for everyone. It's different.
Yeah.
Trial and error.
Yeah, doxycycline just made me more sick.
Yeah, I think
It
that's
made me more
probably
nauseous.
my GI effects too.
Yeah, so for me, I just dealt with it.
Yeah.
Luckily, I had my dance team background, so I knew how to wear
Yeah,
makeup
or that
and
stage makeup.
yeah, and TikTok helped, so just use TikTok and makeup.
That was like, that was the question. Should we start medication before starting MEK for acne and for hair thinning?
Yeah,
But
that seems to have worked for
That
him.
seems to have worked.
But for
If I
him,
would have
yeah.
known, I would have been open to trying it.
Yeah,
but
try it before.
yeah.
my daughter has a plexiform in her eyelid. Does the MEK work for that? I get Dr. Biscaccio.
It should, but the clinical trials were for a certain volume, and it depends on how big that tumor might be in the eyelid. Some of those are pretty easily resected by plastic surgeons who are within ophthalmology. So, and they can do it without the lid actually, running into problems with the lid without losing nerves. They're very tuned in to where the nerves run. So to me, that would be the first question is, can a well-trained ophthalmologist who's got plastic surgery background, can they remove that? And then consider the MEK inhibitor. It should work in theory.
Well, that's great news. Okay, so that is our last question. And I just wanted to, can you see? Yeah. So I just wanted to thank everybody on the panel. You guys were amazing. I just wanted to spend a couple seconds letting you know who the NF Collective is, and you can go to our website if you want to find a doctor. We have a lot of information on there. We're 7 organizations that work together: the Littlest Tumor Foundation, NF Northeast, NF Team, Texas NF, 1722, NF Midwest, and the Children's Tumor Foundation. And if you go to our website, there's a lot of information there on transitions, finding a doctor. And I also want to thank SpringWorks for sponsoring this webinar. Yeah, so thank you to everyone, and have a wonderful evening.
Thank you, Tracy.
Thank you. Thank you guys. You guys were
Thanks,
you
everybody.
guys
Thank
were
you.
amazing.
Thank
Thank
you.
you. Well, it was so good to see you guys. You guys did such a great job.
Thank you.
Thank
Good to see
you.
you.
Good job.
Samantha didn't let me
Good.
talk.
It was really good, right? I enjoyed all of it.
Mhm.
Yeah.
Yeah.
All righty, guys. I'll
All
see
right.
you.
Thanks for
Thank
having
you.
me.
Thank you. Take
Bye.
care.
Bye.
Bye.
Bye.